I'm Peter Rutherford. I'm the Chief Executive Officer for the Rural Doctors Association of Australia, and welcome to our Destination Rural podcast, Series 3. Today, I'm pleased to be talking with Dr Sarah Chalmers, the immediate past President of ACRRRM and a current RDAA Board member, but really looking at her perspective on remote medicine versus rural medicine, and as a woman in a leadership role. I'm really excited to be speaking with Sarah. She's an inspirational leader, but also a good friend. Welcome, Sarah, to our Destination Rural podcast series.
Thanks, Peter. Lovely introduction.
We're going to be talking about your favourite topic today, you.
Yay!
Let's start off. I always find your story a little bit interesting in that you're the child of two rural doctors, but New Zealand born, NT raised, and currently living in Queensland. So I feel like regardless of what sport, what sort of issues going on, you can pick a side that suits you and no one can say anything about it.
Well, yes, this is true. Although I've been known to say on occasions, if you catch me in a Wallabies jersey, call the police, because it's not me.
Oh, it's an imposter. Good to know.
And I guess the other thing to add to that is, so yes, you're right. I am the children of two doctors, two rural generalists, foundation members of ACRRRM, but actually I'm the grandchild of a rural generalist as well. So my granddad was a rural generalist in the Waikato region of New Zealand, just down the road from the Finn family. They were in Te Awamutu. My grandfather lived in Putururu and was a rural generalist there.
When you say the Finn family, which Finn family are you referring to?
The really cool, famous New Zealandy ones.
Oh, okay.
Who did things like split ends and crowded house.
Nice. Okay, that Finn family. Oh.
Yeah. So my mum used to catch the bus up to Auckland to go to boarding school with the Finn brothers.
Nice.
We're practically related.
So speaking of connections, I always think too, it's interesting your year at UQ. There's quite a few prominent leaders within rural medicine. Obviously yourself and also a couple of RDAA past presidents. And just interested, was there something in the water or was there something that was encouraged through uni? It's just interesting to sort of see, these people step up, but all seem to have, some sort of connection when they're stepping up into rural medical leadership.
So I don't think that there was anything particularly special at uni, although we were the first cohort of, what was it originally called? RUSC. And where every medical student had to do a 6-week, 4 or 6 week rotation in rural medicine. So there was that. It was also the first year, and I'm pretty sure, I'm not 100% sure if Adam Coltso had a John Flynn scholarship, but we were the first cohort of John Flynn scholars. And I guess the other thing that was interesting about our year at university was it was the first year of the postgraduate course. So, and certainly in Queensland, it was the first opportunity to, have something other than your school grades get you into medicine. So if it is the case that rural kids who are more likely to become rural doctors at rural schools found it harder to get into medicine, maybe that's why there was a bit of an influx. Because it's not just, John Hall, Adam Coltso, but also people like James Finn, who I think was quite big in RDAQ. Charles Evell was in my class. People like Marty Byrne, who worked out in, rural areas for quite a while.
Yeah, I worked with Marty.
Yeah, there's a whole bunch of people in my class, and maybe there was something, but I don't remember it. I remember, like lots of people say, being a bit of a freak at university, wanting to be. No, I went to medical school to be a rural doctor, and that was a bit weird.
Well, rural doctor or a remote doctor? Because I've sat in a lot of meetings with you where you very clearly, and you're a strong advocate for remote communities as opposed to just the rural cohort, and regularly reminding us all that similar to there's a difference between rural and regional, that there is that difference between rural and remote. So why is that so important? And like some insights, I guess, as to what are those differences?
It is true that I do carry on a little bit about remote, and that is because it's my experience. So I have, aside from doing a couple of days in Ingham a couple of years ago, just as a brief word block, locum. Sorry, I've spent pretty much my entire career since I took on rural generalist training. I've been in MMM7 locations, and what I know about that is that for example, I did my training based in Nhulunbuy, or on the Gove Peninsula in Arnhem Land. And to lots of people, that's a very remote place. And so you can talk about, the rural generalist run services. We didn't have they've only just gotten a CT scanner in the last couple of years. We only ever had one radiographer, sonographer. We had, university graduates, 20-year-olds running our pathology labs. Schools where not very many people did year 12, all those sorts of things that you think about a remote community. But I used to, as part of my first job, fly out to a remote community, Millingimby. And I always used to, as we touched down, so we'd go out on Tuesday morning, work all day Tuesday and Wednesday, come back in, often just as the sun was setting on Thursday afternoon, and I would often, as the wheels touched down, be like, yes, fresh milk and, a proper supermarket where I can, purchase, food, not in a packet, that kind of stuff. So there's lots of stuff that happens in really remote places that even make, there's grades of everything, and sometimes those of us who work in remote talk about MMM 8 to 10, because some of those MMM 7 locations are actually quite luxurious in comparison to, so I had a homelands job where we used to take everything we needed, either in a car or pack it into a plane, fly out into the middle of nowhere to a homeland where there might only be 20 or 30 people, and deliver our primary care clinic off the school veranda or under a tree. And so then, your standard general practice in the middle of Nhulunbuy seems, very metropolitan.
So with, I guess, that remote perspective, I mean, we've been talking a lot in recent months, and it's always a topic of conversation, but scope of practice. And again, I think with that remote perspective, that your take on it is probably a little bit different. And I think rural doctors overall, I think it's a little bit different from their urban colleagues. So do you think that, the direction in relation to multidisciplinary teams that particularly this government is taking reflects what works, or are we still got a way to go?
I think we still have a way to go. I think one of the issues for us as doctors as GPs and rural generalists is that we're not all in agreement. And again, it's probably because of context. And so when we're trying to, we know that we need to be able to present a united front, but because of the different contexts where we work and our different experiences, we see that very differently. So for someone who is based predominantly in office-based general practice, you've got a particular model that you work in. Patients come in and see you, you work in a room on your own. You may or may not, depending on where you are, have a practice nurse that you work with. You might chat to the pharmacist every now and again. But in, the sort of work that I did, there'd be, two people would go out to a clinic and we had certain things that we needed to get done. And if you were it could be two nurses, it could be two doctors, it could be one of each. And every now and again, I would go out on my own and just work with a health practitioner in the community. And so if you've got a bicillin list, for example, so that was, that's how we manage people with rheumatic heart disease. And so normally that's a nurse job. But if there's no nurse and the health practitioner hasn't done IM injections as part of their training yet, then you have to find the people and give their bicillin injections. Similarly, I've had the physio and the OTs give me pieces of equipment and a drill and a basic diagram and say, could you please put this rail into this house for this person? That probably wasn't my finest moment. But, you do whatever you have to do. And
so home renovation's not your strong point?
No, definitely not. And I'm married to a plumber, so, and a builder. So he does all of that stuff. So I've never had to. And yeah, this was kind of my first go and I didn't do so well. But you might have heard me talk when I'm talking about multidisciplinary care, as well as, the other topical thing at the moment is scope of practice. And people want to talk about, being able to work at the top of their scope. And I think that I like to think of it as all of us working in a really broad scope. And what that means is that it's not top and bottom. And so you're not demeaning yourself by working at the bottom. I don't even know what that means. But, if there's a job that is traditionally done by a nurse or a physio or an OT and there isn't one present, then I will do that. If you're busy in ED and there's only two nurses and you need to see another patient, but there's no clean beds, you change the sheets. Now, I've got mates who are emergency consultants and they have never changed a bed sheet in an emergency department. But I know that lots of my rural generalist colleagues do that sort of stuff 10 times a day. So it's about working, making there's a job to be done and someone's got to do it. So I think that...
so full scope. Working to your full
absolutely.
Scope.
Yeah. And in the same way, if there's an RN who's done... who's an expert on wound care and stuff like that, I go to them and say, could you please help me with this? Because I don't know the answer to that. There's all sorts of things that we all do. And so I'm a big advocate for, whoever's there to be able to and to understand that it's part of their role to do whatever needs to be done to make sure that the patient gets the best care possible.
Nice. You mentioned your husband, and I know you've got two lovely daughters. So I guess just thinking about remote practice, how have you coped as a family? And as a remote GP, and then we'll get into some leadership stuff in a minute, but can you have it all?
Yes, let's be positive. Yes, of course you can. It's hard though, and I think that in the same way that we don't, as rural generalists, we don't do our job the way that everyone else does theirs. Perhaps we don't parent the same way. I've worked FIFO. I started working FIFO when Safi, who's now 12, when she was about 6 weeks old. I went and did my first FIFO job, and I took her with me, and found childcare for part of the time, but part of the time I couldn't, and so I just put her in the pouch, and she behaved or she didn't, and I worked around her. I guess I've been very fortunate that by the time, it wasn't so much when I had no, that's not true. With both of my children, I'd been in my community for long enough that people wanted to help me so that I could, provide a service that there wasn't anyone else to provide that service. And so I had, a number of colleagues, nursing colleagues, and either they or their partners would, pick up Emo from childcare, if my plane was delayed, take her home, feed her, and give me a chance to get home, get my stuff together, and then I'd be able to go and pick her up. She'd have sleepovers, with people because I got stuck because of bad weather. And as a result, I think I was perhaps resourceful as an individual because my parents did that kind of stuff. And I think my children are equally sort of resilient and resourceful because that's the way they've been brought up. It's not traditional, but it's just another way of doing things. I think parenting is not about right and wrong. Yeah, absolutely. Yeah. And as long as you can accept that and not feel too judged by, people who are much more interested in more traditional parenting.
Yeah, nice. It's a nice insight, I think, because I think a lot of mums put pressure on themselves to meet certain, tick certain boxes and do certain things, but it's a nice insight and that make it work for you and do it your way.
Yeah, definitely. And again, I think that it's one of the lovely things in rural and particularly in remote communities because you can still be, I have lots of friends who are rural doctors, and you can still be reasonably anonymous in a rural community. It's much harder in a remote community. And if your community wraps around you when you need them. Not all the time. It's not a fairy story. But, there have definitely been times when I've been, I can't get home. I hope somebody will look after my child because, of course, in the remote homelands, you don't have phones all the time either. So couldn't actually ring anyone. I just crossed my fingers and nothing bad ever happened. So, well, not from my perspective. We can interview Emo later.
So you did step up as ACRRM President, but before I get into the, that time and some reflection on that presidency, as a female rural doctor, how important is it? And who were your influential female mentors?
So my biggest influence is my mum, and my dad, really. I mean, in terms of those, I think this is a big thing for rural doctors is that, you've got to do your job, but the only way that we can make things better is to be advocates for our profession and our communities. And both my parents did a lot of advocacy work. My poor dad spent years and years trying to, make the NT chapter of RDAA work and would be up till midnight writing, newsletters and stuff like that. Both my parents did lots of stuff. As I just trying to think, Lexia Bryant I met as quite a young I wasn't that young when I was in the early medical school years. So I was in my rural health club. I was at UQ, so I was a member of Tropic, and I went to one of the NRHN conferences and met Lexia Bryant and Joe Wayner, and they were both really great mentors. Later on, I met Lucy Walters when I first started working at Flinders University. And so Lucy was temporarily one of my bosses for a little while, and I have always looked up to Lucy. Ruth Stewart has been an excellent mentor. Marita Cowie, in more recent years, yourself. And it's not always people who are older than you. I think as you get older and meet new people, so I find Megan Bellow very inspirational. I've worked with some absolutely fantastic remote area nurses who taught me lots of things. There's an entire cohort of Aboriginal health workers, when I was doing my early training in really remote communities when I didn't really know what I was doing as a doctor, let alone, trying to do things in really remote communities. And I got lots of support and, so it's hard, you obviously can't mention everybody's names, but you find mentors, I think, and inspirations wherever you go in, particularly, again, my experiences in remote, it's hard to find people not to look up to.
Nice. So as you were elected as ACRRM President, was that always something you wanted to do, or was it something that you didn't step back quick enough to and found yourself,
I've mentioned both Lucy and Ruth, who said to me as I, started on that ACRRM Council, during conversations, just asking, do you think maybe you'll be the president one day? Do you think you'll join the board? What are you interested in? What can we do to help? When in 2020, we're in the middle of the pandemic, actually the day that the nominations were, the nomination process opened, I got an email from a colleague with a signed, nomination form for the president. A few people rang and said, did you see that it's out? Did you want to have a crack? This would be a good time if you've got the time. I guess, did I set out to be the president? No, I didn't. Did it seem like the right thing to do at the time? Yes. I figured, once I got to the board, I think I kind of thought at some stage I probably will. Because of all of the stuff that was happening during the pandemic, and I was working on Palm Island at the time, and because that community had gone into lockdown, I kind of didn't have a job. Again, it seemed like something that I would be able to do. So yeah, I had to go.
Would you encourage other, particularly, not so much, well, I won't say doctors early in their career, but, doctors coming through and looking and sort of thinking, oh, that's not for me, or, thinking that they have to have done something or achieved something. Do you think, there is that opportunity and just to throw your hat in the ring and have a go, and that, you surprise yourself?
Yeah, absolutely. And, you don't you get the job, but there's heaps of people around to provide you with support. There were very few moments where I felt, completely on my own. And even in those moments where I did feel completely on my own, it was a quick, oh, don't be ridiculous. Of course you're not. There's always somebody to call. It is, it's an extraordinary honour. I don't know if people say that enough. Rural generalist doctors are an extraordinary bunch of people. You hear the things that people do, just stepping up into, all sorts of roles, whether they're clinical roles or administrative leadership kind of roles, people do amazing things, and to be the representative of them is really quite an honour. And so even on the days where I thought, shit, I can't do this anymore, there was all sorts of inspiration to help me keep going. I actually, there was lots of really stressful stuff, don't get me wrong. It's not a walk in the park, and particularly with things like, the vaccine rollout. That was, such a stressful time. I didn't sleep, for almost 6 months trying to work out how we could make sure that, all of this. And you were in a lot of those meetings as well. It was really quite tough. But when I look back on it, I'm quite proud of myself for, doing that. I think I did some good stuff. And I think if there's an opportunity to inspire other people to have a go, like I'm just an ordinary rural generalist like everyone else. And it was a great opportunity.
I think you undersell yourself, considering, yes, you were president through the height of COVID, and particularly the vaccine rollout and everything that happened there. But you're also the president through the transition to college-led training.
Oh, yeah, I forgot about that.
Just a small job.
Yeah.
So, two of the biggest things that have, confronted, particularly the college space, in recent times, obviously the pandemic, but college-led training was also a big change and a big shift. So just, I guess, looking at your whole experience, and you can comment on the transition as well if you wish, but as you reflect back, what would you consider your proudest achievement through your presidency?
That's really hard, actually. I don't know that there is any one thing that I could put my finger on and say, I totes nailed that. I'll probably think of it at like 2:00 in the morning. Can I call you? When I think of the thing? There were some real high points. Getting to give out the awards at the awards ceremony, at RMA was amazing. Giving out FACRMs was pretty amazing. Maybe I am underselling myself. I can't think of something amazing that I personally did. I guess I helped I was part of negotiating how the vaccine rollout worked, being able to stop, at one stage there was talk about, doing a compliance audit on, the COVID vaccine Medicare items. Me and Karen Price and Danielle McMullen and Megan Bellow, kind of got together and, put stuff together to say this is completely ridiculous. That was definitely a high point. No, I can't think of anything else. Sorry.
As you said, you'll think of it at 2:00 in the morning. We'll do a postscript to the interview.
That'll be
right
grand.
then and there.
Yeah.
If you had a wish, what policy change or what system change would you like to see? If you had just, one wish. It can be big, it can be little, but something that you think would actually benefit the system.
I would like to see, what I am really hopeful for the future is a culture shift. I think, there's little gains made along the way in terms of recognising, what rural doctors do. And I know that, it's kind of exciting to think that we might be recognised, rural generalism being recognised as a specialty within the scope of general practice. That'll be great. But I know that rural and remote doctors work really hard to advocate for their patients, and often have a really tough time with, big metropolitan hospitals who don't understand what it is that we're trying to, just exactly what it is that we're trying to do, and the circumstances that we're working under in being able to do that. And so I'm not sure what the policy shift would look like, but there would be, and I guess it's on the back of what happens with a better culture. But I would really like it to work in a much kinder space where we actually look after each other. I often, we work hard to look after our patients, but we don't get looked after by the system. And I'd like to see a system that looks after us a little better.
Nice. Well, we're just about to finish up, but I like to finish with a bit of a quick fire round, of quick questions, and you just answer with whatever pops into your head. I think I'll know the answer to the first one, but we'll see. Favourite singer?
Oh, Taylor Swift.
Yeah, the greatest philosopher of our time.
The greatest philosopher.
The best place you've ever worked?
Lane Point Homelands.
Okay. Favourite thing to do when you're having me time?
Nothing. I like doing nothing.
If you had your time again, is there one thing you'd do differently?
No.
Nice. And final question, the best piece of advice you've ever received?
Just get on with it. That's what both my parents used to, there's all sorts of things that you could complain about as a kid, having to do the vacuuming or, something like that. When I became a rural generalist, I would come up against stuff and often ring my parents for advice, and they would say, well, you could do this, you could do this, you could talk to this person, you could go there, you could whatever, but just get on with it. Because you've identified that stuff needs to get done.
Dr. Sarah Chalmers, thank you for joining me, and it was a pleasure.
Thank you so much, Peter.